know from studies over many decades, and particularly studies from South America, South and Latin America, that people also learn a lot through other forms of incidental learning in their communities, in their families, across the life course. So it's not all about formal education, but there's no doubt that formal education is foundational in a community, in a society, in building literacy. What we've also learned is that our ability to use these generic skills of reading and writing and numeracy can be very significantly influenced by the context in which we're trying to use them. What we know is that even a person who might typically be classified as having high levels of literacy skills can still find difficulty in using these skills in an unfamiliar, intimidating environment. An example what I would always use is somebody with a high level of literacy who's going into a healthcare environment, may well be feeling quite stressed at the time, and is then faced by somebody using medical terms that they're not familiar with, they don't use in their everyday language. And even though they're highly literate, we find they have great difficulty in applying these skills in circumstances where they're a bit stressed and where they're faced with unfamiliar concepts and language. So literacy is contextually specific. And what you'll find in the literacy world is that there are a whole range of different literacies. And these days we talk about helping young people to develop financial literacy skills, helping older people to develop digital literacy skills, all of us needing to acquire better environmental literacy skills, and so on. And in among this growing interest in specific forms of literacy, the ability to apply your generic literacy skills in a specific context, the concept of health literacy has emerged over the last 25 years, specifically to help us understand what we need to do to help people use their existing literacy skills in a health decision-making context, and to develop those specific skills in health literacy. So there's this fundamental relationship between underlying literacy skills and the ability to apply them in health-related decision-making. We also know from studies over some decades now, certainly as I mentioned, I first became interested in health literacy through the study of the relationship between literacy and health. And we know from studies conducted both within countries and between countries that there is a fundamental relationship between low levels of literacy and poorer health outcomes. Some of this is due to the societal impact, societal determinants of health. So for example, people with lower levels of literacy are often less able to engage in economic activity and often end up in poorer occupations, poorer employment, lower lifetime income. And we know that these have substantial long-term impact on people's health. But there are also some much more direct impacts of low literacy that have been observed over some decades now. People with lower levels of literacy in general are less responsive to conventional health education, particularly that's health education that's dependent on a lot of writing, the written word. They're less likely to use disease prevention services, conventional services such as immunization and screening services. They're less able to understand and use successfully prescribed medicine. And they're often far less able to successfully manage chronic disease, something that's becoming increasingly important in our population, in our countries with aging populations. All of these effects combine to mean that underlying inequalities in health are exacerbated by low levels of literacy. in populations. They're not made worse. And the converse is also observable. As populations expand literacy, particularly some of the lower income countries, as they expand literacy, this has a quite dramatic impact on the health of their communities and society, particularly where education is expanded for women and children. So, summarize in a nutshell what we think health literacy is. It is this ability to apply generic personal skills and abilities, literacy skills and abilities within a specific context. And that context moderates our ability to be able to use these skills. So health literacy will always be defined in these two different ways. On the one hand, it has to do with the individual and their skills and abilities. And on the other hand, it has to do with the context in which they're looking to apply these skills and abilities. And the reference to the original diagram is included on this slide. Health literacy has also been defined in a rather more sophisticated way. In this case, this is the definition of health literacy that's most recently been adopted by the World Health Organization. And I should acknowledge the contribution of my colleague, Christine Sorensen, who's with you, I think, at this meeting, for her contribution to this definition. But it highlights two or three consistent themes. First of all, health literacy is based on personal knowledge and competencies which accumulate through daily activities, including formal education, as well as social interactions and other exposures to health information and communications across the lifespan, across the generations. Secondly, and importantly, our ability to use this knowledge and competencies is mediated by the organizational structures and people's access to resources that enable them to firstly access, understand, appraise, and then use information to make decisions about their health. And the last part of this extended definition that I want to draw your attention to is that it is found, health literacy is founded on inclusive and equitable access to quality education and lifelong learning. This is in the World Health Organization Health Promotion Glossary and was originally referenced in a paper that I wrote with a colleague, Danny Muscat, also published in 2021. So what's the relationship between health literacy and health education? As I mentioned, Professor Correa wanted me to particularly draw out some of these issues. Well, the first thing to say is health literacy can be improved through formal health education, structured communication, and incidental learning. This is consistent with the definition that I just gave to you, but health literacy can be improved through health education. And something I've personally always championed is that health literacy can also be seen as a measurable outcome to health education. It's one way in which we can assess whether or not we're making progress with our efforts in health education. Health literacy is an outcome to health education in the same way that improved literacy is an outcome to formal school education. There is a fundamental relationship between the input, the activity, which is education, and the outcome, which in this case is literacy or health literacy. Now, my own view is that we also need to consider this in the broader context of the place that health education has in a wider model of health promotion. And also, we need to remind ourselves that formal health education, the type of things that we may get involved in as a structured approach to communicating with people, is increasingly one of many exposures that people have to health information across their daily life. As the formal definition of health literacy reminds us, health literacy is formed through daily activities, social interactions across the generations. What I'd like to do is use a model I've used for many years to position health literacy and health education within a broader model for promoting health. And I'll do that quickly using a logic model. Now, logic models, for those of you familiar with them, are ways of making a connection between a set of actions and a range of intended outcomes. As this indicates, this model that I'm going to show you now was actually first published 25 years ago. I've actually adapted and updated it quite a lot since then, but nonetheless, the basic structure remains in place. For those of us interested in improving health in our populations, we need to start at the end. So what's the end goal? Well, we want better health outcomes, reduced avoidable morbidity, mortality, and disability. And many of us are also interested in improved social outcomes. We want to help people improve the quality of their life, maintain functional independence, and above all, we want to contribute to equity in our society. So we have a set of outcomes in mind, but in many cases, what we are doing in health education is a long way removed from those health outcomes. So we've developed our understanding of what it is that determines those outcomes as a target for a lot that we do in health education and health promotion. And so some of the things we target are, we want to help people to improve their lifestyles, quit smoking, to be physically active, make good food choices. We want people to make best use of available health services, especially primary health care and prevention programs. And we want to create a healthy environment, one that is safe, one that provides nutritious food, reduces exposure to tobacco and other harms in the environment. And those are the determinants of health that are often the focus for our activities. We want to help people make good choices as individuals. We want to encourage them to use the healthcare system as best it can be used, and we want to try to create a healthy environment for people. What makes a difference? What is it that we can deliver on that would actually start to influence these things? And I've identified in this model 3 broad areas of change. One is we can improve people's health literacy. We can improve their health-related knowledge and skills, their behavioral intentions, and their confidence to act, to make good decisions about their health. Secondly, we can influence social norms and public opinion, and we can help people to mobilize collectively to take actions that will improve their health. And thirdly, we can look to influence public policy through legislation, regulation, and through organizational practices. These are what I've described here as immediate impact measures, the things that we can target to make a difference. The final part of the model is what I've described here as health promoting actions. And you'll see we can take health promoting actions with individuals. Health education would be a classic example of this, where we're trying to work with people as individuals through school, through the media communication, through direct-to-patient education in our healthcare system. But we also work directly with families and with communities using conventional community engagement and mobilization methodologies, as well as more direct collective educational activities. And finally, we can work through and with our national and local governments to ensure that the type of public policy that we want to see in place is followed, and that the resources required to enable us to do the other things are also made available to us. And so you end up with a more complete model that begins with a set of different types of health promoting activities, is followed then by an examination of the immediate impacts that these can have, that is linked directly to the determinants of health, and progressively over time, that has an impact on health outcomes and social outcomes. And you can start to play with models like this. Now, a temptation is to draw a sort of direct link between work that we do in health education, improvements in health literacy, changes in people's health-related decisions, and better health outcomes. Those of us who've worked for a long time in this field will always know that, of course, it's far more complex than that, and it's never a simple set of linear relationships across such a complex ecosystem as the one I've described here. Nonetheless, we can start to look at different ways of working. Our health education can be focused on improving lifestyles, but it can also be focused on encouraging people to make the best possible use of available health services. Health literacy, improving health literacy, can also be linked to mobilizing people to work collectively, take social action for health, and in turn, that can have an impact on public policy and so on. I'm not going to pull out the full extent of this model, because there would be an arrow linking almost every part to every other part. It's a dynamic whole. What I want to avoid is the idea that there's some simple linear relationship between one action and a long-term outcome. It doesn't work like that, and we have to recognize that we, for example, our health education can directly improve health literacy, and that in turn can directly influence people's health behavior choices and their use of health services. It can get them involved socially, collectively, in action to improve health and so on. So logic models, whilst it's useful to see the whole picture, and it's useful to see one way of linking health education to health literacy, to good health decision-making, to health outcomes, logic models are just that. They're a model. They're not a way of explaining causation. What they are, as it says here, is a structured framework that allows us to organize in a structured way the actions that we take, the expected outcomes, and the long-term direction of change that we intend. They do help us make explicit the assumptions that we have about potential impact and outcomes. As it says here, what will happen, in what order, with what anticipated effects. Importantly, I've found that using logic models can help us as practitioners or researchers and evaluators to communicate among ourselves and more clearly to stakeholders, especially people who are funding activity, what to expect over what time frame, and in doing so, help us better manage unreasonable expectations, often from impatient politicians and funders. So logic models are useful to get a sense of the whole picture, to get some sense of the relationships, but they're not a causal explanation. It's really important for me to emphasize that. What I hope you can take away from that is that health literacy really matters in this complex ecosystem. In health and education and social systems, it matters where we need more effective approaches to prevention and health promotion. It matters in health and social systems where there's a commitment to person-centered care. It matters a great deal where there is dependence on patient self-management, particularly patients in our healthcare system with chronic conditions who need to be personally and actively engaged in their own healthcare. And health literacy really matters where there's a commitment to equity. There's a strong social gradient in all national surveys of health literacy. And the fact of the matter is that those with greatest need are often those least able to respond to the demands of our healthcare system and are less responsive to traditional health education, something that we have to give a lot of attention to as we develop this link between health education and health literacy. The other thing, the last thing I want to mention about health literacy before moving on to thinking about how we can improve health literacy is that in countries that have undertaken national health surveys, and Christine Sorensen may be able to speak much more authoritatively than I can, for example, about survey work that's been done in European countries. This is a study from Australia. It's a little bit old now. It was done in 2008. But the reason I use it is that although there are some really excellent self-report measures of health literacy, this was a direct measurement survey. In other words, the participants in this survey were asked to perform literacy-related tasks. They were asked to read something and then interpret what it meant and what actions were implied by what was written. So they were, for example, asked to perform a task such as using information in text and in a graph to assess the safety of a product, or to be able to understand and interpret the dose on the recommended dose on a bottle of medicine, or to understand what 1/3 meant. So these were very practical health decision-making tasks that were presented to a broad cross-section of adults in Australia. And I think nationally we were shocked to find that 2/3 of those nearly 60% of those participating in the survey were classified by the Australian Bureau of Statistics as having inadequate health literacy. They were not able to perform even some quite basic tasks, literacy tasks, that would ensure their safety and enable them to make good decisions about their health. And this led to some significant national action in Australia to try to address low levels of health literacy in our population, because clearly it was having an impact on people's ability to make good health decisions on behalf of themselves and their family, and has become an important national priority in Australia since this time. Now, the more encouraging part of what I have to say is that we can improve health literacy. As I've mentioned several times, health literacy ultimately describes an observable set of skills. These vary from individual to individual. They also vary from situation to situation, as I've described before, but they can be measured and they can change after intervention. And some years ago, I wrote a paper drawing upon some excellent work in the study of literacy to classify health literacy in 3 different ways: functional health literacy, interactive health literacy, and critical health literacy. And the reason I want to mention the differences between these 3 types of health literacy is that one of our goals is to try to help people move from being functionally health literate to being critically health literate. And to do so requires us to think quite differently about the ways in which we communicate, the content and form of health education that we use with people. So beginning with functional health literacy, this describes basic health literacy skills that are sufficient for people to obtain and apply health information, usually to complete defined activities. So there's a picture here of a young person learning how to use an asthma inhaler for the first time, or someone who's been diagnosed as diabetic, receiving information on how to better manage their nutrition and insulin. Very goal-directed communication, purposeful, task-based, very functional. Person learns a specific skill and is better positioned to improve their health as a consequence of learning that skill. So very functional health literacy, very important, nothing wrong with that. And a lot of our health education and patient education activities are highly functional. They're designed to encourage and support people to make quite specific decisions and behavior changes in their lives. The second level of health literacy, though, describes something that's much more interactive, more advanced skills that enable people to find and assess the quality of information from a range of different sources. So most people these days, particularly because they have access to online information, have access to a wide range of different sources of information. Being able to sort through where to go, what to trust, how to use that information is quite an advanced skill, and we have to help people develop those skills. Importantly, it's not just that people can get access to information, but also that they have the skills and confidence necessary to apply it in different contexts, to be more confident as consumers of information, to be more confident, for example, in interacting with healthcare professionals and with people who are providing health information. So that's interactive health literacy. I hope it's obvious that that requires a quite different set of skills and will require different approaches to health education, patient education, and health communication. The most advanced set of health literacy skills, so-called critical health literacy, that's intended to help people be much more critical consumers of health information, to understand the source and purpose of information. I've included here an illustration of a range of different health claims that can be found on food products. I have to be honest and say a lot of these are misleading. They require quite a lot of consumer skills to be able to understand who's telling me this, what's the source of the information, and what are they trying to do? Actually, in most cases, trying to get you to buy their product or buy more of it or consume more of it by the way in which they present the information. So I hope you can see again a rather advanced analytical skill that we now are trying to help develop in our public, in the general public or our patient populations. It also implies that we are including in the content a much broader understanding of the impact of a wide range of social, economic, and environmental determinants of health. So it's not all about personal decision-making, personal behaviors, personal use of healthcare system, but also understanding some of the factors, some of the determinants that are constraining choices and limiting people's options to do the right thing for themselves, their families, and their communities in improving health. All of this is intended, firstly, to enable people to exert greater control over their life circumstances and the events and situations that they may find themselves in, and also to equip them with skills to work together with others in order to advocate for change, particularly in some of the broader determinants of health. And again, I hope it's clear that this is a quite different set of health literacy skills from interactive skills that I described earlier and functional skills, and that it has real implications for style of communication and content of communication in health education. So summarize that part, we can improve health literacy. It's not a static construct. You don't become health literate when you're at school and nothing ever changes. The reality was we're exposed to a wide range of health communications every day, and this has an impact, dynamic impact, on our health literacy. If we actively look to help people improve health literacy, our goal here is ultimately to promote greater autonomy in decision-making and personal empowerment, a really nice fit with broader concepts of health promotion. Progressing from functional to critical is dependent upon, first of all, the development of practical skills, finding, praising, understanding, and using information, the creative use of media, recognizing that people have vastly different preferences for the way in which they access information and use different media, and also requires us to expose people to different forms of information. So it's not just about people and their behaviors, but also about the social, economic, and environmental determinants of health. And we have to recognize all the while that all of this is moderated by the context in which communication occurs. So what we might do, an approach we might take in the community may be quite different to an approach that we might take to communication in a hospital setting. What we might do in interpersonal communication, one-to-one, might be quite different to what we might do with a group or a class, different again to what we might do online, and different again to what we might do in more conventional printed media. So again, very dynamic environment, but progress is possible. It requires a focus on practical skills, creative use of media, and recognition that the content of our communication needs to become broader in many cases. So how do we change things? I'm going to summarize briefly some of the key elements of bringing about change before reaching a few conclusions. One of the fastest things we can do is to insert an active verb into this model. So our goal is developing personal skills, reducing situational demands and complexity. How do we develop personal skills? Well, firstly, we have to find ways of improving access to accurate and trustworthy information. And secondly, we have to communicate with people in ways that help increase their skills and confidence across the life course. How do we reduce situational demands and complexity? Well, we get better at health communication, improving the quality and reach of what we do as communicators. And we also work to improve what I've called the information environment here, both within our organizations, in schools, in clinics, in hospitals, and online, and increasingly trying to find ways of working effectively online is going to become very important in the future. And it's a dynamic whole. Not all of us can do all of these things, but we do at least need to understand that they are interconnected, and we have to optimize the contributions that we can make in what is a quite complex and dynamic information environment. Very briefly, touching on some practical ways in which we can work. How do we improve the quality and reach of health communication? What we do? Well, firstly, we need to make sure that all of our frontline staff, doctors, nurses, teachers, are aware of health literacy as a concept and are trained in effective health communication. And there are some fantastic health model curricula that have been developed over the last few years, particularly for health professionals, and some great publications. Don't need to start from scratch. There are already some good models out there to achieve this. Second point to make is because national surveys consistently have identified that very high proportions of the population have low levels of health literacy, regardless of the level of literacy overall in the population, there's a high risk of misunderstanding at all times. And so we have to take universal precautions. All our health communication should be at the simplest, easiest to understand level as a starting point. Those that are confident and able to seek more information can and should do so. But as a starting point, we have to make sure that all of our health communication is kept as simple and clear as it can be. We know how to do that. We know, but we consistently fail to implement. We can use simpler language, and there are a lot of tools available to help us do that, including and specifically some of the recently emerging AI tools like ChatGPT and Bard. These will actually take a complicated concept and will provide you with a plain language explanation of that concept as a starting point. Please have a look at some of these tools. Hemingway Editor and Grammarly are two other online tools that you can use to help simplify the language that you use in your communication. More importantly, and over the longer term, trying to get people engaged in their learning in interactive ways is really important. In the healthcare system, this means using techniques such as teach-back and shared decision-making, and I'd encourage you to find out more about these methodologies if you're working in a clinical environment and are regularly communicating with patients or members of the public. Improving access to accurate and trustworthy information online. This has been a big deal over the last 5 years, greatly exacerbated by the challenges that have emerged during the COVID pandemic, where there was a lot of misinformation and disinformation. People have got to be able to find accurate, accessible, and trustworthy digital platforms to get health information from. Sadly, despite all good intentions, the vast majority of health websites are written in language and use formats that for most people are inaccessible, just simply too hard to follow, too hard to use language that people aren't familiar with. People don't use them. And often, sadly, will go to alternative sites that are not as accurate or as trustworthy, but are very accessible. So it's a real challenge to us as health information providers to get this right. And there are three really critical features that we need to look to get this right on any online information that we provide. Firstly, we have to make sure that people know that it's coming from a trustworthy source, a source that they can trust for quality, relevance, and timeliness of information. And yet you have to provide information on all of those elements. Why should the person reading this website trust you? How do they know the information is relevant and timely? Basic information that can be provided on all websites and is not. Secondly, we have to design websites and other digital platforms that are actually make the information that people need and find relevant immediately accessible, easy to understand, and allow people to build up their knowledge and confidence because they can navigate the website easily. This is not a feature of most health websites at the moment. Finally, a range of digital technologies now are enabling us to create much more interactive platforms where people can get personalized messaging, can get feedback, and can actually monitor changes in their health status. So we've got to do these three things as we design online information: build trust, ensure access, and foster engagement. How do we work directly with consumers to increase skills and content? I've mentioned most of this before. We've got to get the content right, moving beyond simple instructions and recommendations to interactions that foster understanding and help people to understand what both enables and restricts their choices and the actions that they can take. We need different forms of communication, less didactic, more interactive, whenever possible, really practical and empowering wherever possible, based on collaborative learning. Last thing to say is that we have to become more sophisticated in matching consumers the people we want to influence with the media that they actually use. One of the things I think we learned during the COVID pandemic in Australia, where we have very diverse population, is that generic messaging through typical mass media was not reaching the vast majority of the population, and it required much more sophisticated targeting of messages and media in order to begin to engage the populations we most wanted to engage with and to get them interested and motivated in, for example, getting immunized against COVID. Improving the information environment is something that we've less experience with and are beginning to understand a lot better. One of our big challenges, I think, is in making our own health services more easy to access and to navigate, making it easier for people to find both the information and the services that they actually need. And as I've noted here, this is not easy, but there are some really useful, practical guidelines that people can use to help them steer their way through what are significant concurrent changes at multiple levels. One example I've given here comes from the Australian state of Tasmania, and there's a link on the slide if you want to have a look at this. But it highlights how you have to involve the hospital leadership and make sure that they're on side with change. You have to get advice from consumers about what they need and what they're looking for. You have to train the workforce, have to recognize that one approach won't meet all needs, that we have diverse communities with different needs. We need to focus on some of the practical issues of how you get access to healthcare and how you navigate the healthcare system. And most of all, we have to get our communication right. In the online environment, I think governments around the world are really struggling with this at the moment. In Australia, we currently have a major commission looking into ways in which we can better regulate the online environment so that people get access to quality, trustworthy information of all sorts, actually. Digital technology provides great access to a much wider range of health information and advice, but unfortunately it also provides equally easy access to inaccurate and often deliberately misleading information, especially through social media. What we've discovered through our research is that a majority of people actually use quite low quality websites when looking for health information, even people with higher levels of health literacy. As you'll be aware, there was tremendous challenge with misinformation during the COVID-19 pandemic, but usefully, the WHO developed a number of helpful tools that you can use in thinking about how you respond better to misinformation online and how you direct people to more trustworthy sites for them to use. But it's a real live challenge that countries all over the world are grappling with at the moment. So in summary, how do we move from these theoretical ideas to practical action? Well, just to summarize, firstly, health literacy is both content and context specific. There isn't a single thing that you can do that makes someone health literate. And we have to work at building health literacy across the entire life course, not something that happens at school and we never think of it again. Secondly, we need to remember that most people experience difficulty in finding and using the health information that they need. And we have to take universal precautions in response to this, ensuring that all our health communication is as accessible and understandable as possible for all people. Thirdly, we know that health literacy can be improved through health education and skilled communication. Making change, though, requires both a focus on helping people develop skills and a focus on reducing some of the environmental demands and complexity that make it difficult for people to use those skills. What are our responsibilities as frontline practitioners and researchers? Well, firstly, as trusted sources of health information, we have a responsibility to get our communication right. And we fail so often to get this very basic thing absolutely right. But we do need to train people so that they're competent to be good communicators. And one of our roles is to make sure that we are engaged personally and that we engage others in training in effective health communication. We want to get our health organizations, also our schools and other educational organizations, understanding the importance and value of health literacy and providing overt support for effective health communication within their organizations. We know how to communicate effectively. We, though, unfortunately, consistently fail to put what we know into practice. So it's a constant reminder that we have lots of tools available to us to do a better job than we typically do. We need to make better use of them. Finally, what does effective communication for health literacy actually look like? Well, very simple mantra, you're getting the right message to the right person at the right time, using a media that they prefer to use. We're finding ways of directly engaging the public and patients at all stages in the development of communication and in the delivery of communication. It's feasible to do, and we get much better outcomes when we have consumer engagement in the development of communications and in the delivery. We also know that interactive communication is what builds transferable skills that move people from functional health literacy to interactive health literacy to critical health literacy. It's finding ways of engaging people meaningfully in interaction with the messaging that we have and building on that, collaborative learning where there's trust and respect between the learner and the communicator creates trust, mutual respect, both between learners and also between the educator and the learner. Thank you very much for your time today and for paying attention through such a lengthy lecture. If you want more information, over the last 20 odd years, I've been writing books, short books intended for frontline practitioners and advanced students that are intended to explain theory of health promotion as simply as possible, how to evaluate health promotion programs as simply as possible. And the most recent publication due out in the next couple of weeks is Health Literacy in a Nutshell. And I hope that you'll find any and all of those useful to you if you want further information. Thanks very much for your attention, and I hope you have a great and very successful conference. Bye for now.
Okay, thank you for stay till now. Gracias por estar hasta ahorita. Bueno, gracias por haber estado pues hasta el final de la conferencia. Entonces ahorita pasamos a un conversatorio corto, teniendo en cuenta los tiempos, pues para que también podamos ir a descansar. Entonces, pues quiero que las personas se sientan libres de ir haciendo sus preguntas. Allí tenemos un micrófono disponible para quien quiera ir haciendo alguna intervención alrededor del tema de la conferencia que podamos conversar con la profesora Cristina. Voy a poner unas sillas aquí adelante para que... Dos, sí, por ahí. Allá hay una pregunta.
Vale, buenas noches ya. Digamos que para las personas que nos acercamos tal vez por primera vez a este concepto de la alfabetización en salud, por supuesto que resulta no por menos, digamos que llamativo poder establecer como esa diferencia entre educación para la salud o educación en el campo de la salud y alfabetización en salud, porque cuando uno ve la presentación, pues hay elementos que son muy comunes, digamos que a ambos conceptos, pero hay uno que particularmente a mí me causó curiosidad y es entender si para aplicar este concepto de alfabetización en salud se requiere que previamente el personal o la persona o la comunidad sea alfabeta, o sea, esté alfabetizada, porque pues digamos que en la presentación se veían unas variables que dependían del nivel de alfabetización de las personas para después aterrizar en el concepto de alfabetización en salud. Y pues en un contexto colombiano, digamos que todavía hay un grado importante de población que puede ser que no tenga la alfabetización básica de lectura, escritura y manejo numérico. Entonces no sé si haya una relación realmente entre esos dos conceptos o fue que me lo imaginé.
Yo voy a traducir para que ella pueda avanzar con la respuesta.
So this is, yeah, thank you for the very important question. And I think it comes up everywhere where we discuss this topic around the world. Health literacy is a very academic term. So, and it's very difficult to translate the term into different languages. And Liliana and I had a discussion today. In my language, in Danish, we call it health competencies. In Dutch, where I lived for 10 years, it was called health skills. And in Portuguese, it's literacia em saúde. And you call it alfabetización y salud. So if I translate alfabetización in my language, it would be more or less only about reading and writing. But if I have it in my language, health competencies, it's much broader than reading and writing. And your question is, where do we, so what does it link up to, how does it link up to education then? So I see two different approaches to health literacy around the world. NotBeam is very much linking up to literacy and as an outcome of education. Literacy is an outcome of education. Health literacy is an outcome of health education. In other parts, it's more broadly related to life skills. So it's, he also mentioned this is part of other life skills like digital literacy, financial literacy, and so forth, where it's one of many literacies. And one does not exclude the other. It's more how much do we zoom into the to the details. He also mentions it, and I believe so, it changes over life. So where do we get in touch with health literacy? I used to work in a kindergarten, and for children, it's all about learning to eat apples and not sweet, or brush your teeth every day, or wear a bicycle helmet, or so. And with teenagers, it starts to be new topics, sexual education, perhaps, alcohol, smoking, and so forth. When we are elderly, it's work-life balance, maybe less stress and mental issues. When we are older, it's healthy aging. So that's what he means with content and context-specific topics. And these issues are the same as we see in normal discussions about health education. They're not, they're the same. But for me, it helps to think about health literacy as the outcome of health education, what we teach, but really with the view on what should they know, what is important to know. And that's cultural. So I come from Denmark, but I lived 10 years in Netherlands. And when we moved, my children were 3 and 5 years old, and all the parents said, you need to teach your children to swim. And I said, why? Because there's so much water. They have a lot of rivers and channels and so on. But in my country, we have a lot of water as well. And we also think it's important to teach children to swim, but we do it as part of school when they're 7, 8, 9 years old. But in Netherlands, it was when they were 5 years old. And you had to go and get a certificate, and it costed 300 euros. It was quite expensive. So it became a business model. And I thought, okay, why is it important in one country and not in another? You have countries where bicycle helmets are compulsory, and in other countries you can go without. So health is so much related also to the context, to culture, to society, to values. And I think this is what he means. There is no one universal answer. We try to, in health promotion, of course, in health education, to find some universal topics. But when we translate it into daily life, people's daily life, there is a filter related to their beliefs, to religion, to habits, to demands, to societal demands. So they don't do what we want them to do, coming from a health professional point of view. But this is where education can make a difference to their health literacy. So it's a long answer to a short question, but I hope you can see that they are so interlinked. And what I recently did was also to look at how can health, so we usually say that education helps health, but there is also the other way around. Health helps education. So healthy students are better students. So the arrow goes both ways.
Perdonad un comentario porque me parece muy interesante ya aterrizarlo muy concretamente como ella lo dice, porque en mi campo de interés, entonces, la educación sexual daría como resultado alfabetización en sexualidad, o sea, adultos sexualmente alfabetizados, por decirlo de esa forma, teniendo, digamos que, la explicación que ella hace. Entonces me parece muy interesante.
So let me explain right now. I'm doing a review of health literacy in Africa, and it turns out that there are many projects on sexual health literacy, HIV health literacy, AIDS literacy, reproductive health literacy. It has different names depending on what we want to do. I'm sure we can find the same for South America. We should get more in Europe, I think. But yes, and that's just what we mean. We are talking generally about health literacy, but as soon as we dive in to our topics, you have that area. Others work with cancer literacy, diabetes literacy. It's getting much more nuanced. And for every topic, we need to find the level of knowledge and competencies that people need to have to act, let's say, responsibly or help themselves to live good lives.
And I want to add something about the concept of literacy, because it's an important issue. As Ok. Que ella hacía referencia a algo muy importante que quiero resaltar y tiene que ver con cómo se traduce o cómo se comprende eso de literacy. Porque, cierto, nosotros lo traducimos como alfabetización y también para nosotros significa esa competencia de lectoescritura, pero ella hacía la referencia a que no lo están comprendiendo así, ¿cierto? Por ejemplo, en ciertos idiomas como danés, no se comprende, pues también se hace la referencia a alfabetización como lectoescritura, pero literacy no significa lo mismo. Entonces hay un poco de confusión también de acuerdo a la forma en que se entiende el término.
Christine, I have two questions. Voy a decirlo primero en inglés y después los traduzco. I was talking before that it is important to know all the trends, different trends that we have in health education, or we can say that. Here, in this conference, we have been talking about health education, in Spanish, educación para la salud, popular health education, critical health education, and health literacy. We can say there's more or less 4 trends that we can find in health education. So the question would be, why talk about health literacy? Why is it important, this concept? What are the distinct principles that say, well, this is health literacy, and this is why we are, how you say, putting forward this concept. We want to talk about health literacy. And the other one is that you have been working a lot in Europe, and there's a lot of development. It will be nice to know the experience you have had putting forward this concept, and how is it being developed in Europe. Thank you.
Yeah.
Sí. Yo les pregunté por qué se habla de alfabetización en salud. Tenemos en el Congreso pues 4 propuestas: alfabetización en salud, educación popular en salud, educación crítica y educación para la salud. Entonces, ¿cuáles son esos principios o esos elementos distintivos que a uno le dice, bueno, esto es alfabetización en salud? Y lo otro que le pregunto, porque ella ha tenido una experiencia muy importante en Europa, impulsando y, digamos, promoviendo la alfabetización en salud en Europa. Entonces, que nos cuente un poco de cómo está ese desarrollo en Europa.
So let me start with the second question first. It's the easiest one. I don't know. So my history to this field is that I was invited to be a coordinator of a new project in Europe on health literacy 10 years ago, 2009. I did not know what health literacy was. I never heard about the term. But I got a job, and part of the job was to do this project. So I started like everybody else, read all the papers and get into it, and saw the names. Not Beam, that name came up many, many times. So I was reading all these the papers, and we developed our project, and the main aim was to measure health literacy in Europe. Our politicians in the European Commission was inspired by work in the US, Australia, elsewhere, and they wanted to know if health literacy was a problem in Europe. So we developed, based on our literature review, a definition, a model. I will tell about it tomorrow. and the questionnaire, and we measured it, and we saw the same results like Dot Min saw in Australia, with up around 60% having limited health literacy. And it came as a shock to many of our researchers, colleagues, but also policymakers. And we said, why do we see these results when we think in Europe we have good educational systems, we have brilliant healthcare systems, we have big societal, social systems? What's wrong? You know, why do we see, is it maybe the measurement is wrong? Can be. Maybe we understand the concept wrong. Maybe. But there is something there. And this result is there despite health education. We've done health education for many years, many programs in health promotion, many interventions, many programs part of school education. And still, people don't do what we tell them. They take their medicine wrongly. They don't participate in screening programs. They do not take vaccinations. They don't wear the bicycle helmets. You know, lots of frustrations. And we could measure that. And that's the health literacy part that comes into play. And we try to look into it. And there are different definitions, but they are very overlapping. I don't think they're different. I think they are very overlapping. They all add different types of it. But the core parts are people able to get access to information? Can they learn? Will they have these programs? Can they understand what they're being told? Many people, much of what we produce of information and programs are so complex that people don't get it. And that's on us. And can they assess, can they value if this is good for them? And do we give them any alternatives? Very often we don't. We don't give them. We just tell you, you have to do it like this. This is the right thing to do. We know best. This is our attitude from health promotion, from health education. And that's, you know, that's not always best for people. People live their lives. And what they're interested in is having a good job, be able to earn their own money, take care of their family, see their friends. That's what they're talking about. We are talking about, prevention, tobacco, alcohol, all these things. These are academic terms, right? These are professional terms. People don't care. They just want to have a good time with their friends. So we see this. That's the reason why we saw these issues are because we are not meeting the demands. The bubbles that he showed many times, we're not doing a good job. And that was a big hit in our face as professionals, that even with our good education and health education, there is still something we miss. And that is where we can zoom in on health literacy and look at, okay, can we do better getting people access to, making access so that people can find their information on websites? But very often websites are so confusing. So there we can do something. Can we speak in a more easy way for people to understand? Can we use less jargon? All these tips that Don Nabin was giving. And can we make alternatives? And why should we make alternatives? The best we can do is ask people. We had a speaker this morning who said nothing without me, for me without me. But very often we forget to ask people what's important to them. And then we can have our answer, and we can combine and do informed and shared decision making. But our systems today are not designed around shared decision making. It's like a factory, you know, you want patients through the system. 15 minutes, or I don't know so much about your systems in Latin America, but I know the Danish system, the Dutch system, it's about, there's no time. Personal values don't count. Personal preferences don't count because it's all about money. But sometimes they forget, if we had listened in the first place, we would have found a better solution. And I think that's where health literacy matters. So for me, to your first question, health education is also a professional term. And it's very much the way we think as professionals. What's the education, information people need? But we need to combine it with the personal preferences and personal beliefs and personal culture and the culture in context within it serves. But there's very much overlap, of course. That's mentioned, and also the health education becomes very much about interventions and formal education, but a lot of health issues are learned as informal education and non-formal education through the communities and groups where people participate. We saw it with vaccinations during the pandemic. These were clusters of mis and disinformation. You can read a lot about statistics, but you would often still lean on an advice from a mother or a sister or a brother or an uncle or someone you know, and they may not know the statistics. You can read all the statistics, but if you hear from somebody else, oh, you should do this, who would you follow? And that's where I think health education, we still have that kind of professional approach to it, but maybe we can broaden up, soften it. But that's where the discussion is. So for me, it makes sense to see health literacy as an outcome of health education, but formal as well as all the other things that shape us and shape our knowledge, our competencies, our motivation. So it's a complex issue, but yeah, very interesting. And I don't think we should stop health education. This is not my point. I think we should definitely continue health education. And I see health literacy more as a lens that can help us refine, so we can take it to even higher levels than what we do now, because what we do now is not enough. That's what the statistics can tell us.
Thank you. ¿Hay una pregunta más allí?
Hola, Christine. For me, it was very important to hear the conference and you, the last thing you said, because I think it is a challenge to the health literacy to make some connection or relationship between literacy, formal literacy, and I don't know how to say this, but not force the knowledge that we know to the knowledge of the communities. And maybe I think it's possible that when we practice health literacy, can stay or can force to people to learn some things or some behaviors that they are not interested. And maybe we can make some kind of violence to these people, to this community, because their knowledge is different and is based in another behaviors and another ways of lives, different types of they live, and the way that we think they have to live. So I think this is a challenge. So what are the strategies to not do this?
It's a very relevant question, and I think for me this is where seeing it as a health literacy issue helps us to make it make sense for people. Because if we take it our way, what we know is right from our research and our knowledge, our expert views, it does not always make sense to people, and therefore they do not act. Why should they? But if we take the health literacy lens to it, we have to make sure it's made available, that information or the knowledge available in a way that makes sense to them. It can be online, it can be oral, it can be through a community leader, it can be peer-to-peer, whatever. There is a channel of communication we need to look at to make sure it makes sense to the the one we want to engage with. It has to be understandable. So, for example, in my country, a municipality, they were giving maternal education, maternal health literacy. They were giving small courses to new parents about their children, childcare. And they normally would give a nurse, child nurse, and she would come and give PowerPoint presentations like we just saw. But there were certain groups that they can't read very well. They can't follow this way of thinking. It's an academic and way of explanation. So they started not to come. And so there were big groups that we were never reaching in the municipality. Then they took another approach, very practical approach. They invited them to come. They bought a doll and a little bathtub, and they were showing how to do it with the baby doll, and they enjoyed it. They had good laughs. It would change the atmosphere. It was not this academic, you, me, but us, you know. So this was a way they could better understand. It was the same message, but the wrapping was different and the context was different. And then it's about, choosing what's right for me. So giving, again, as I say, more pathways for people to choose, because some people want that, there's no one size that fits all. That's the main thing, but we tend to forget that when we share our knowledge. And lastly, it's about applying the knowledge. And sometimes we are not strong enough in actually giving them good direction. What's the next step? How can they act? What's the next type of behavior? Or we concentrate too quickly on behavior, the behavior change, but we forget all the steps that need to be in order before. So finding, understanding, appraising and applying information is the essential part here. And there's so much we can improve to make it better for the people we want to serve.
Bueno, por la hora creo que podemos ir cerrando la sesión. Mañana pues va a haber un poco más de alfabetización en salud en la conferencia central, entonces pues están todos invitados a seguir profundizando un poco en este tema. Muchas gracias por la asistencia.